Okay, we can go on and we will take the questions, and then we now come to the lens-induced glaucoma. And yes, there are a number of types. It can be an open angle variety, it could be closed angle variety, the phacolytic, phacoanaphylactic, phacomorphic, and microspherophakia lens particle type. Lens particle is one of the common things that we see now. पेशेंट हमारे पास रेफर होकर आता है कि सर बिल्कुल ठीक कैटेट किया था, प्रेशर बहुत बढ़ गया, सर समझ नहीं आ रहा क्या हो रहा है. And then you dilate, and when you look inside, you'll find either the whole bloody nucleus lying there somewhere, or there'll be part of something lying there, and obviously there'll be flare. It could be very, very obvious, but there could be variable amount of flare, coronal edema, even there could be a hypopyon. Obviously, it could be something very frank lying over there. If it is not frank, you should dilate the pupil, look everywhere. There could be just some lenticular material lying somewhere. And you can keep treating the glaucoma, you can start doing so many things, but unless you actually remove the cause, it's not going to work. So many times in such situations, we will have to do a vitrectomy, whatever you do. So many times we have to involve, especially with more advanced cases that I am seeing, retina surgeon is a part of my practice, invariably. For so many cases, we have to do vitrectomies. As far as the phacolytic is concerned, again, it is an open angle variety. The capsule is intact in these cases. And it is the outflow pathways, the proteins are leaking through the intact capsule, and it could be early when it could be just directly blocking the thing, or it could be late when actually the macrophages engulf it and create a problem. Again, phacoanaphylactic is a technique, trick where it actually broken the capsule. And in these cases, again, there is intense flare, inflammatory reaction, and the trabecular meshwork is clogged. You can even see a hypopyon. Anyway, the treatment for most of these situations is entirely similar. We'll come to that later. Phacomorphic glaucoma, we all know it's a secondary angle closure kind of variety. We rarely see it now. Obviously, previously this was the commonest thing, that whenever you used to go to the camp, half the patients are blind because of this kind of glaucoma. So luckily it has come down with very good cataract surgeries in the peripheral centers. And obviously it is the cataract which has become bulky, it is pushing forwards, and you can see that it's forming an iris bombay, and then later blocks the periphery of the iris also. Sometimes abnormal lens positioning, like either the lens has got subluxated and then it presses on the periphery, or it could be just that there is a microspherophakia and the lens is round and then it is causing a pupillary block. As far as the medical measure is concerned, entirely similar. As far as anything else is concerned, it should be treated with, if the pressures are very high, please remember that if you start pumping in medications, a lot of people will give a lot of drops, the pressures are 50, nothing is going to happen because the drop is not going to go in. So first let's get the pressure down by either giving an intravenous mannitol. Before you give a mannitol, please be very careful, auscultate the chest, the patient should not be in a partial flow. LVF, we have had patients who have gone into serious trouble after giving mannitol. So be very careful that it's not in a kind of a heart failure or something like that. You can, if that is contraindicated, you can give oral glycerol, you can give Diamox, and beta blocker and alpha agonist obviously are the commonest thing that we use. You cannot use pilocarpine, you cannot use prostaglandin analogues unless the inflammation is controlled. You control the inflammation by steroids, and obviously you can give painkillers. You can even use homite at time. As far as the lens component, when it moves forward, obviously ultimately we are going to remove all these lenses, but the question is to first get it under control. Then only you can go in for the lens surgery. So another interesting thing was that in some of these situations you can do actually a peripheral iridoplasty, in which you stretch out the peripheral iris and give large spot size of around 300 to 400 microns in the periphery, and you can give 80 spots all around, 0.3 to 0.7 watt power and 0.15, 0.2 seconds. The idea is to stretch out the iris and open up the angle. So what is closed angle here actually opens up widely over here, and this works in almost any kind of glaucoma. So please remember, gonioplasty is something which works where nothing else is working. And obviously this is a surgical emergency, but you will not like to touch an eye which is very, very high pressure, because the chances of expulsive are very much. So with all these techniques we will try and control the pressure for some time at least. And then you can go in. The big question in all these situations is that should I do only so many times I'll get a phone call, sir, kya karna hai, aise hai, should we just remove the lens or should I go for a combined? So that is an important question for you to answer. क्योंकि lens करके बैठ गए and then again you are going to give post-operative steroid, फिर pressure बढ़ेगा and it will be out of hand sometime. So you have to be very very clear. अगर तुमने मैरिटॉल दिया है सारी चीज़ों से simply आराम से pressure अच्छे से control हो गया है, then definitely you can just go in with a cataract extraction. But if despite all the therapy you see the pressure is 20, 30, 35, 40, it's not getting easily controlled, then you know that even if you do a simple lens extraction, many a times you land up with a secondary glaucoma which will be untreated. So in these situations, and again if you do a gonioscopy, you find there's already an extensive pass. If the patient has been like that for quite a long time, classically there is a 72 hours, but you have to judge by yourself. And if the patient is going to have a poor follow-up, then perhaps you would rather like to go in with a combined surgery. And surgery is going to be difficult. You have to give IV mannitol because the disc may be compromised. You can't see the disc. So please avoid giving a super pinky. Do a gentle massage. Always use viscoat. Make a small rhexis in the center because it will tend to run out. And first make a circular rhexis, put in a needle over there and absorb some of the lens matter. And then further you can enlarge the rhexis gradually when the pressure in the lens becomes less. Femto is indeed a good option. Initially when one of my fellows started doing, I said, what the hell, how can you do femto in this? But if the pressure is well controlled, it will give you a beautiful rhexis. Obviously it cannot cut the section inside the lens, but it works beautifully as far as the rhexis part is concerned. It will give you a perfect rhexis. In difficult cases, if the IOP is not settling by any means, it is 50, 60, and you have to go in by any means, then please remember that is the time we call in our retina surgeon. He does a 23 gauge bit and just do a core bit. Everything settles down, the chamber becomes deep, and you can do a nice cataract extraction. If you have no facility, you can push in a needle of a wider gauge, 23, 22, 21 gauge, and try and suck out some vitreous, but it is very, very dangerous. So the best thing is that if you have a surgeon with you, nothing like it. Thank you very much.